I got to upload my talk. Oh, we're still here? Oh, Ron, okay, yeah, okay. So, sorry. Ron needs no introduction, but Ron's going to give actually a great talk on drug-coated balloon technology, variety of uses, so stay tuned.
Thank you, Ajay, and thank you for having me again at this CCC course. Actually, it was asked to give an exciting topic because I've heard about drug-coated balloon, I think since 2000, something like that. So this is like 23 years. We hear how the Europeans are doing it, how they advancing it, and we are just now started a US trial for in-stent restenosis. So it isn't exciting. I think there is a transformational shift. These are my disclosures. So we'll talk about the evidence, safety, indications, some opportunities, and then we'll try to put everything in summary. So first, let's talk a little bit about drug-coated balloon. I think over 60 years, we've seen a lot of progress in the coronary tree. You can see that drug-coated balloon came basically to place after DES, after the second generation DES, and then in the middle, there was a BVS. The concept was nothing leave behind. But the first drug-coated balloon was not perfect, then came the second one, and now we are even talking about the third generation drug-coated balloon. So for those who are not familiar with the technology, DCB have been around, but you have to have a balloon surface, some matrix coating, and then you have active drug. Until recently, it was only Paclitaxel, but now we have also SIROLIMUS. And then you have excipient to be able to carry the drug and deliver the drug to the tissue. Now, with respect to the excipients, there are many of them. And again, there are different generations of drug-coated balloon. As we mentioned before, it was started with Paclitaxel, and now we have third generation with SIROLIMUSes. Now, as a matter of fact, drug-coated balloon is a kind of a local drug delivery device. You have the drug on the balloon. You have to deliver that. You have to make sure that on transient, the drug is not going to disappear. And you have to dwell the balloon for at least 30 to 60 seconds to make sure it's going to be in contact with the adventitia to make an effect. So what are the elements of an effective drug-coated balloon formulation? First, you have to mass deliver high quantities of the drug within seconds, distribute within the medium in the first few days, and you can measure that actually in preclinical and pharmacotherapy studies. Then you're looking on the therapeutic drug levels that must be maintained at least for 4 weeks. It must allow rapid healing as compared to drug-eluting stents, and probably will have an advantage that it would not require dual antiplatelet therapy for a long period of time. There are some biological effects that can be observed immediately on preclinical studies at 28 days. And some of this can be observed also in humans when you look on angiograms. Some of those has been reported with some sort of aneurysm or lack of healing. So we have to be worried about that. But the bottom line, you have to deliver the drug to the tissue. And one of the concerns about all those excipients, because they can shear off the balloon and could have some particulates downstream. So we have been seeing over the past 20 years numerous balloons. I'm not putting all of them here on the slide, some of them. But the lesson that we learned that DCB are not equal with respect to the technology. There are different doses, different drugs, different excipients, and different outcome. So we have to be, there is much more variability with drug-coated balloon compared to, for example, drug-eluting stent. But the first data that was convincing that something here is working was a series of PEPCAD studies that were performed by Bruno Scheller, who actually was the pioneer of this technology. He has his first study published in the New England Journal of Medicine for the treatment of in-stent restenosis, again, POBA alone. And from that on, there were small vessel diseases and other retrospective studies. Overall, we've seen efficacy in bifurcations, in combination with bare metal stent, in combination with drug-eluting stent. But the key utilization of that, even in Europe, was for in-stent restenosis and only recently in small vessels. Now, again, as I showed you on the PEPCAD studies, they all were small, and they were not enough to draw definite conclusion. But when you don't have it, you have meta-analysis. So overall, they were looking on nearly 4,590 patients that enrolled in 26 small randomized clinical trials that were published between 2006 and 2019. And overall, you can see that they were favoring the drug-coated balloon versus whatever was the control alternative therapy. So overall, it is really a crude analysis. I don't know how much we can rely on that, but it was all on the same direction. So as a result of that, the ESC added to the guidelines, and it's now recommended for in-stent restenosis. It's a class 1A indication, and I think people are using it in Europe. Not all of the cases, because again, it's more expensive than drug-eluting stents. Most of the data that is available is for bare metal stent in-stent restenosis, but most recently there is also data for DES restenosis. As a result of that, DCB has been penetrated worldwide, except you see the big America. Basically, it's still in the gray zone. We don't have the technology available. There are concerns with DCB that we should be aware, primarily flaking of coating during the delivery. And this could lead to some particulates. They can go downstream. They can maybe cause some microvascular disease. But it looks like the arteries are very forgiving, because we have not seen serious reports of adverse events with those particulates. Some of them were resulted for some slow flow, but the histology is much more convincing. You see here fibrinoid necrosis, platelet emboli, and crystalline material. So it depends also on the excipient that is being used, and some local inflammation as a result of that. And again, the other thing that could be a result is delayed healing, especially when you use high doses of paclitaxel. That's something that needs to be concerned. Now, on the clinical side, there was a very famous meta-analysis of Castanos that basically presented higher mortality with paclitaxel's dark-coated balloon. But again, it was a meta-analysis. It came all the way up to a panel of the FDA. The FDA issued sort of a dear colleagues letter. It was not a warning letter, but be careful. But overall, when we look at the totality of the data, we are now almost 4 years after this publication of Castanos. It looks like everybody is easy, and there probably were other reasons to see higher mortality with the paclitaxel arm on those studies. So I think it became now for the periphery the standard of care for SFA lesions. Now, again, indications, we mentioned a lot about in-stent restenosis, but I think the concept which is appealing is really going back to leave nothing behind. We don't need actually the stent except to tackle dissections or if there is a severe recoil. But other than that, why do we need that? And we are not seeing also for those who are using that for de novo lesions, subacute closure that we used to see with POBA in the old days. So that may be because we prepare the vessel well, maybe because we are using antiplatelet therapy, but we don't see acute closure with de novo lesions. So the rationale for drug-eluting balloon now is not just to compete with drug-eluting stent, but actually to be a first-line therapy if you don't add with dissection. Obviously, you do need a very good vessel preparation. But there are some other indications beyond that. Among them, again, we mentioned periphery in the US. It is approved, and it became like the standard of care, almost first-line therapy for SFA lesions. Below the knee, we're still struggling. We don't have a good data to support conversion to use, and it's actually not approved for below the knee. Coronary, talked about in-stent restenosis, de novo. Small lesions are probably the first one, and then bifurcations. And then there are some studies on AV fistula, and believe it or not, even for erectile dysfunction. So this is being used widely for all those indications. Question about the de novo lesions. And we are looking actually on the first device that probably will be approved in the US within a year. It's going to be drug-coated balloon called the Agent of Boston Scientific with Paclitaxel. And this actually was studied on a randomized study, 2-to-1 randomization, the Agent Paclitaxel versus plain old balloon angioplasty. We holding fingers that the study would be positive. Enrollment was completed. 1-year follow-up. It will be presented to the FDA. I would make a guess that the study will be positive, and this balloon will be the first to be approved for in-stent restenosis. But again, as I mentioned, you have basically, once this is approved, three options: DCB alone strategy, DES alone strategy, and some hybrid. And again, you have to find what is the sweet spot for DCB, and it goes for young patient that may not want to commit to a stent. If you have someone with a high bleeding risk and you don't want to be committed to long-term antiplatelet therapy, versus patients who have ischemic risk or they have unfavorable balloon result. And then small vessels and distal vessels that you really don't want to use stents if you don't need to, and you also don't want to see restenosis. So we have seen a study that actually was done, I think with Dr. Colombo, the Bello study. It was one of the first one that was looking on small vessels, and actually it did carry on all the way to 3 years. It was more a mechanistic study, but again, you can see that DCB was doing better against Paclitaxel. So maybe it's not fair because we're not using Paclitaxel. But following that, there was basket small study, number 2, and this has also showed that DCB can compete with drug-eluting stent. And it did show non-inferiority, but again, if you show non-inferiority, you basically win. Now, bifurcation, we discussed that today through the live cases. Again, it's about more the side branch. Instead of putting another stent, sometimes you can also use it for the main branch. So if you have a bifurcation. So again, it's a very attractive, and there are small studies that have been done in this field. This is kind of lumping all those data together, showing again in the blue the DCB was slightly better than a DES if you're using that for side branches. So again, required more studies, but it is an attractive approach. So to summarize this de novo hybrid with DES, I think first and foremost, we have to do good vessel preparation. We have to go back to the basic of balloon angioplasty. Once we have it, and if we do it correctly, then we can apply DCB, and most likely it will take care of the neo-intima formation. We're not going to see late recoil. We're not going to see any other issues. We're not going to see stent thrombosis and not in-stent restenosis. So again, we will have to go through some algorithm, and I can predict that Kinney will come 2 years from now with a nice app how to use DCB and when to use DCB. Cannot wait to see that app coming along. Now, opportunities. I think we talked a lot about Paclitaxel because most of the data that we have with Paclitaxel, but we do know that, well, everybody remember Renu Vermani, she one time stated, why not Paclitaxel? And we know the limitation of Paclitaxel in terms of the window of therapeutic that could be very narrowed between toxicity and efficacy. And I'm not going to dwell on all these, but there are differences that actually try to push us to SIROLIMUS. And why not SIROLIMUS? We know that from cytotoxic to cytostatic, the area that it works on the cycle, it is actually safer drug. The question if it's going to be strong enough to dwell in the artery and to be effective to reduce restenosis. So some studies actually, when they looked at that, they did show the following, that when you're looking on SIROLIMUS versus Paclitaxel, you potentially, with SIROLIMUS, you reduce the toxic effect. And at some instances, if you're using the right excipient or technology with macro reservoirs and others, which I'll share with you in a second, you can actually still get very nice PK data to show that you're going to have an effect also with SIROLIMUS. When we look back into our DES, we know for sure that DES with SIROLIMUS was outperformed the Paclitaxel, and that was through numerous studies. So the question is, can we duplicate it or replicate it in the DCB arm? Again, I'm sorry that the studies that are available are very, very small. And Bruno Scheller, again, he looked on 50 patients with in-stent restenosis, and he compared DCB with SIROLIMUS versus Paclitaxel. He got the same outcome. But again, we're not going to make determination based on 25. We have patients on each arm. We need to have much larger and robust program. And there are actually two companies that leading the LIMUS. One of them is MedAlliance, and this is a list of studies that they are doing. And they started small, but right now they have large studies that are emerging, and I'm going to share with you. And there are some other companies, Sequent Please, which is probably the most, I would say, old company that has been using. And again, they are using 4 microgram and Magic Touch 1.3 microgram. And then we have also BA9 biosensors with 3 microgram. And then you see the differences also in the excipient. So some of them are crystalline, which could be wary, and some of those are inside polymer microspheres. So there are different technologies, and we'll see who's going to be the winner. This is the Med Alliance, the SIROLIMUS. They have a proprietary microreservoir technology, and they have a miniature drug delivery system and cell adherent technology, which again, it's a proprietary technology that helps to get you the drug into the lumen, into the adventitia, and stay there. So again, you have a mechanical approach by the balloon, then you have some electrostatic mechanism to make sure that the drug would adhere to the adventitia, and then you have the biological effect. When you look on the PK data compared to Science and Magic Touch, it looks pretty promising. So I'll just now show you the solution is in the black and the Science is in the red. They're almost similar. So again, if we can achieve a Science-like PK data, that probably should work. Again, the other advantage of the solution SLR that there is no flaking. So that is important because we don't want to see any crystalline or any other particulates going downstream. They have a very robust study, including a US study that they just launched about a few weeks ago. That's a SELUTION ISR IDE with 418 patient study. And there is also a very large solution, the NOVA study going in Europe with 3,326 against drug-eluting stent. So this study actually will challenge drug-eluting stent. And again, if it's showing non-inferiority, I think that the balloon is winning. So this is the study design that's going on right now in Europe. And it's going very fast. About a third of those patients already has been enrolled. So that's very encouraging. And so far, the DSMB allowed to continue the study. That's also encouraging. And it's going to be interesting to see and to watch what's going to be the impact of DEB versus DES. This is the US study. So this is the one that we are participating. Sinai is a high enroller right now in the US. We are second. It's a one-to-one randomization of a standard of care. There is also option to do POBA if the patient had 2 layers of stent, and if they had only 1 layer of stent, the randomization is DEB versus DES, and there is also imaging sub-study. I mentioned that there is another company that also very active in terms of studies and technology, very interesting, is the Medic Touch. They do have delivering the drug in 60 seconds. The dose on the device is 1.27 microgram. And they have been doing a lot of small studies in Europe. This is one of them, again, in native coronary vessel disease, almost all the vessels from 2.0 to 3.5. They have also small vessel disease, diabetic program, all over the place. We just have to wait for the results of those studies. And this is their US trial design, to the best of what I know that is updated, which is 2-to-1 randomization on the mechanistic side with OCT. So that would going to show the effectiveness based on OCT. So that's a very revolutionary way to look on efficacy just by OCT. And then there is also a registry of 300 patients for safety against performance goal. So this is the study design, and again, should be started soon. Again, how do you do performance goal? You look at all the study that has been done so far. This actually not that hard to achieve. I think 46.6% MACE at 1 year. So if they are okay with that performance goal, it's probably going to get approved. So I can project that if the technology is working, in few years we'll have at least 2 systems with SIROLIMUS-based drug-coated balloon approved in the US. So let's summarize everything. I think that we have to recognize that, in my opinion, the biggest role of DCB or DEB is leave nothing behind concept. We do allow by that to preserve the physiological vasomotion, not caging the vessel. It is very attractive, and you may not need the stent unless you have to tackle dissections or recall. SIROLIMUS is now challenging PTX, and if those studies will win, I think everybody will shift to SIROLIMUS because it's still considered to be less toxic, although the data with PTX is pretty good. And then I think that we do have recognized that we have a lot of small studies. We do need the large studies. They are coming in the US. And although we are late, we're going to give the definitive data. And if the studies will be positive, I think the future of DCB is rosy. And we probably will convert big chunk of our DES practice to DCB. So stay tuned, enroll into the studies because this is coming. Thank you.
Thanks so much for that. That was a great tour de force summary, and obviously you're leading many of these trials and very involved in the space. We actually have Antonio who's going to be presenting a case later, and I think he'll hopefully present his strategy for using DCP because it's a completely different strategy than many of us are used to. And it's actually interesting for me. I saw Antonio at PCR doing some of these cases, and I remember as a fellow, it was like miles and miles of stents everywhere. This is back in 2004, 5, 6. And now it's the complete opposite, and limited stents, a lot of DCB, a lot of imaging as well. So pretty interesting.
Yeah, in all of those, you know, it's always somewhere in between. The truth is not one side or the other side. But I think we shifted too much to stenting. We're going to go back to balloon. We'll find the right spot.